Onc Live Insights is a video editorial program produced by Onc Live.
So one of the greatest things about being an oncologist is that we're the educators. We're the communicators of complex information, often multidisciplinary information from surgery and radiation and radiology and everything else. And we're the conduit. We're the primary caregiver, if you will, for most cancer patients. And so we're it. We are the synthesizers. So there's nothing more important about an oncologist's job than communicating with the patient. Whenever there's a patient in front of me, it's an evolving process. New patient, you walk in, you don't really know them. You know their medical history. You sit down, you have a sense of their education, you have a sense of what they'll know and not know, but you don't really. And so from the first visit, you're beginning a discussion where you're tailoring what you say to a patient based on what they're getting. So it's a constant back and forth. You've got to look your patients in the face. You've got to look the caregivers in the face so that you get a sense of whether they got what you just said. You have to pause and ask, did you understand that? And sometimes they'll tell you, sometimes they won't. So you have to watch for recognition. There'll be plenty of patients who come in who've done their journal reading, know exactly what all the words are that you're saying, and have already pretty much trained themselves to come in. And then there'll be others that have not looked at a thing, want to be naive, if you will, about the whole thing, and you've got to start from scratch. So I think a key initial interface is all about judging what a patient knows, what they don't know, what they're getting, what they don't get, and along with that, what they want to know and what they don't want to know. My new patient visit really starts with warm introductions. You go in, you say hello, you say, glad to meet you, actually sorry to meet you, because they don't want to be there, quite honestly. But you have to really remember that that patient, it's just the next patient for us, but that patient has been waiting for that visit for a long time. They've been anxious about it, they've made notes, they've prepared, and we sort of casually go in with the next. That new patient visit is really an important moment. So introductions all around. I usually ask a few kind of icebreaker questions. One of my favorites is I just ask, what do you do for fun? It's the last thing they're thinking about. They have cancer, they're in an oncologist office, they're not thinking about fun. But you learn so much about a patient from a simple kind of off-putting question like that. What's their life like? What do they do? You know, how do they think? You know, you learn a lot, and it's kind of fun for them. So try some endearing initial discussion. And then, of course, you want to make sure you got the history right, you do your physical exam. But for me, I then sort of stop, and then we have a long talk. I tell them that most of the visit is going to be a discussion. I give them a sense of how long this visit's going to be. I might even prequel, if you will, what we're going to have to decide at the end of this. Do we take chemo or not? What approaches? Which thing first? That kind of thing. So that they're listening for the deciding factors. Now, a lot of times you can actually cover everything and leave with a decision. But there are a lot of times when you can't. You need more information. A test will change your decision, or you're an opinion and a patient wants to ask others. So you have to set in the context what the goals for that visit are. Are we going to decide something and start it? Are we only going to move the bar a little bit for later decision making? How we exchange information today with patients is multiplexed, right? The traditional way is they come to the clinic and we have a visit and we discuss. The second of those is a phone call. You pick up the phone and you talk with the patient. But of course, electronics nowadays, we're emailing back and forth with patients, and most systems and docs don't mind that. Many docs have given cell phones. Now, I'm not so sure about that, but the communication is real time. A lot of my interaction and behavior with patients has been influenced by my own personal experience. So I thought I was a pretty good oncologist until my wife got breast cancer. So when my wife gets bad breast cancer and everybody thought she was going to die, you know, what you want to know, you want it now, we did, we want it now, we want the explanation, and we want all the information we can get because we're going to process and try to restore order, right? Now, not everybody's like that, but I recognized just how hard it is to be a cancer patient or the family of a cancer patient. It's so disruptive, it's so unsettling, that if you can be kind of immediately responsive, if you can make yourself available, it lowers the tension. And patients are immediately respectful of when you're busy. They really get that you're busy. But knowing that they can reach out and that you will get back to them is so settling for patients. So whether it's traditional face-to-face, whether you're a phone person, whether you're willing to, face chat, whatever that's called, no, FaceTime, that's what that's called, with a patient, that's really, your own call. But recognize what the other side is doing. There's this thing that patients talk about called scanxiety. So whenever they have an event, whenever there's a test, a CAT scan, a blood test, that's a major deal for them. They might be dead or alive based on that test, or their cancer treatment may be working or not. And you got to know that as soon as that test has been done, they're already stewing on it. When am I going to get that result? What's it show? I have two kinds of patients with this regard. I have the patient who wants to know now. And they often befriend the radiology tech and everybody, so they leave with a report. I've got others who are like, no, I'll talk to you in a couple weeks. It's like they take the test and then they wait for their scores to come back because they need a little process time. So we have to recognize scanxiety in our patients and the power of the information we're transmitting.
As an oncologist, though, I think it goes back to, number one, understanding the social support system of the patient, though. So who's responsible for assisting the patient currently? Are they living with a spouse? What is their activity level? What is their social situation? And the reality is that religious factors can come into play, ethnicity can come into play, but you need to be aware of it, and you need to be able to understand that people are going to be of varying degrees of education and multiple different types of ethnicities. It's very, very important to really talk, when you meet the patient, number one, make sure that they are comfortable with you talking to their family members. In my case, I like to make sure that the patient is really our number one priority. And if he's comfortable with me sharing the information with their family members, I think that is fantastic, because then everyone's on the same page. My concern is when you have family members that don't want you to tell the patient that they have cancer, and they do not speak English, and so it complicates things quite a bit. However, in that setting, I think it's lucrative to have an interpreter present. I never use a family member as an interpreter because misinformation can easily be provided, and then you end up in a very difficult position down the road when you think this whole time the patient has had a complete understanding of his disease and why you're treating him with the various chemotherapies that you are, and what approach you're utilizing. And so it's very, very, very important, I think, to make sure that for a patient that does not speak English as their primary language, you need to have an interpreter present. And it's very simple. You can even utilize that dial-in service that's a low fee, and I think that's very reasonable. It's best to have a real-life interpreter present, but that's not always the case for all physicians.